Everyone. Hope everybody had a lovely 4th of July weekend, and welcome back for our NeuroWellness talk. My name is Catherine Kiefer. I am the Neuroscience Program Manager at Rush University Medical Center, as well as the Patient Education Manager at Nira Medical, and the president and co-founder of the Brain Health Center of the Rockies, a 501c3 nonprofit organization in Colorado. Tonight, we're going to talk about fatigue and MS. And as many of you know, fatigue in neurological disease is more than just exhaustion. It can profoundly disrupt daily life, function, and well-being. Tonight, we'll be looking into the pathophysiology, the causes and types of fatigue, as well as how it is measured and comorbidities that can contribute to MS fatigue. We will also discuss lifestyle management, exercise, symptomatic therapies to help with fatigue. As always, we intend for this session to be interactive and would welcome you to use the chat box at the bottom of your screen to ask any questions that you have. And we will take time and stop and answer as many of those questions that we can within this 1 hour time frame. Tonight we have two great speakers with us. We have Dr. Augusto Miravalle and Dr. Christina Weber. Dr. Augusto Miravalle is a leading physician and researcher in the field of multiple sclerosis and neuroimmunology. He currently serves as the chief of MS and Neuroimmunology Division at Rush University Medical Center in Chicago. He is deeply committed to improving patient care and outcomes. He spearheaded the development of the Brain Health Program at Rush, which provides integrative multidisciplinary approach to MS care. He is also the co-founder, along with me, at the Brain Health Center of the Rockies, which provides brain health education to individuals with neurological conditions. With a passion for teaching, Dr. Miravalle also develops innovative fellowship programs in neuroimmunology, focusing on multidisciplinary care, team-based care, and translational research. He is recognized as a leader in the field and has been instrumental in shaping the future of MS care and research. He is joined by Dr. Christina Weber. She is a doctor of nurse practice, specializing in multiple sclerosis. She earned her undergraduate degree from Bethel College in North Newton, Kansas, and her graduate degree from Creighton University in Omaha, Nebraska. She has been working strictly with MS patients for the past 6 years and currently offers care at Advanced Neurology in South Denver, Colorado. I would like to kick us off with a very basic question. So if you could perhaps let the audience know as we start this conversation, what is MS fatigue and how is it different from the normal tiredness?
Sure, I can take that one. Thank you, Kathy, and on behalf of Nira Medical for inviting me, and thank you, Christina, for joining this panel. MS fatigue is, as you know, it's very common. Patients, up to 70 to 80% of patients with multiple sclerosis will experience fatigue at some point in their life. And we traditionally divide fatigue into two types. One is what we call primary fatigue. And of course, we have then secondary fatigue. So primary fatigue is usually the results of MS itself, the inflammation that actually is part of the pathogenesis of MS is going to cause a lot of consequences in the brain. One of those consequences has to do with the impact on how these networks in the brain work. And anytime you have a system, if you compare your brain to, let's say, an electrical system where you have, signals that have to travel through wires, and if that system becomes less efficient, all of a sudden you're going to increase the demand of the function of the brain. So that's kind of like in a nutshell how we explain primary fatigue, which is the result of inflammation that has consequences in the efficiency of the networks in the brain. is going to increase the demands on the brain, and one of the consequences, the brain is going to be tired. The second type of fatigue is what we call secondary type, and that has to do with factors that are often associated with MS or as a consequence of MS that may impact the way the brain functions. And one of the typical one is sleep disorders. We know that MS patients, up to 30 to 40% of MS patients will have some sort of sleep disorder. And of course, if you can imagine, if you don't have proper rest during the night, your brain is going to be tired, and all the functions that the brain is going to be involved with are going to cause more fatigue. Another example of a secondary cause of fatigue is hormonal changes, and the classic one will be thyroid disease, and or perhaps low testosterone in men. So there are many hormones that actually could be altered in the process of MS, and some of those will cause fatigue. But also, in a very common one is depression, and patients with MS also may have depression as a consequence against of MS, and sometimes depression is perceived as fatigue. So those are the two different types of fatigue that we often encounter.
Yeah. I'll add to that. A lot more research lately has been coming out or being focused on like the menopause period as well. So that's something that counts as that secondary type of fatigue. And oftentimes the primary and secondary, we won't know what we're looking at or what we're working at. They kind of overlap each other. And so we try to work with both.
I think that's a really great point, Christina, and thank you for pointing that out. There's so many of MS patients are women, and it is oftentimes difficult to kind of figure out exactly what might be causing the fatigue. But I think so often it is overlooked that many women going through their menopausal stage are potentially facing that aspect as well that contributes to the fatigue. Thank you. So talking about fatigue, I think and again, just mentioning how it can be difficult to determine what potentially is the cause. How is the difference between perceived fatigue and measurable fatigability? Can we speak a little bit about that?
Sure. So I'll start just by fatigue in general. It's sort of, I compare it to pain a lot. My background was all in hospital medicine prior to neurology, and pain was always called the fifth vital sign, and it's kind of what the patient says it is. That is fatigue to me. It's physical or mental, even emotional tiredness, exhaustion, the feeling that each patient, whichever male, female, they perceive it. It's how they perceive it. So if they're telling me they're fatigued, I'm believing that they're fatigued. That compared to what we call fatigability is more of the muscle's ability to work. So you're fatigued, maybe you wake up in the morning and you're already tired, then you try to work out and your muscles they can't produce that power. That is more fatigability, is how I would describe it.
Yeah, actually, I love that description, Christina. It's so important to validate those invisible symptoms in MS, whether it's pain or fatigue. Those are symptoms that often are so prevalent and affect so much our patients' quality of life that often when their providers are not acknowledging that or they don't validate that, there is some degree of frustration that happens. So it's so important. I love your comparison that I think the first step in approaching fatigue is number one is validate the symptoms. And sometimes I even try to overestimate because patients often get used to their fatigue and that becomes kind of like part of their life. So they don't think is such a big problem because often there is a habituation that happens. So it's important sometimes to be able to measure the impact of fatigue. And there are some tools that we have, and I'm a big fan of one that we use in every patient called the modified Fatigue Impact Scale, or MFIS. And it's a very brief questionnaire. Those are 21 questions. It takes roughly 3 to 5 minutes to complete. It gives you a total score of fatigue, kind of like a composite score, but also gives you 3 subscores that represents the 3 main domains of fatigue, meaning the physical fatigue, the cognitive domain, and the psychosocial domain. So basically, is that a mental thing? Is it mental fatigue? Is it physical or fatigability? Or is perhaps psychosocial factors, the most common one being depression, isolation, or so on and so forth. So I think there are some tools we can use to help kind of dissect fatigue into measurable outcomes. But as Christina mentioned, the number one step is to validate that.
Well, so let's speak maybe a little bit about, can disease-modifying therapies or other MS medications themselves cause or perhaps worsen fatigue?
Yes, both ways, right? So I will say the older therapies that we used in the 90s and early 2000, the interferons is the classic example, right? They were the first drugs approved for MS, but they came with a lot of side effects. Among those, it was these flu-like symptoms, depression, and fatigue. So luckily, we moved on from that phase. And now, the new highly effective therapies, we actually see the contrary. We see that patients with highly effective therapies, whether the typical or the infusible therapies, ocrelizumab, ublituximab, as well as natalizumab, they often have showed in real-world studies that actually patients have less fatigue and over time, and that has to do perhaps with what we were talking earlier, that primary fatigue component, that you are affecting directly that inflammatory component of the disease that is going to allow the brain to function in a pseudo-normal, less inflammatory way.
Right. And I'll add to that. And you mentioned over time we can see it improving or even preventing some fatigue in some ways. But there can be, for some patients, side effects to those where you'll have a shorter time, maybe with infusion, or a short time after infusion where you experience fatigue, but overall fatigue can be improved.
Dr. Miravalle, you had mentioned MFIS. Can you tell us again what that acronym stands for exactly? What that is?
Yeah. So it is a 21 questionnaire. It's called the Modified Fatigue Impact Scale, or MFIS. And is readily available. And actually, if you search it online, you're going to find a PDF and you can download that. We measure that in every patient. It's a great way to kind of quantify it. But also, one of the clinical usefulness of this test is that, as Christina mentioned, sometimes patients come with a complaint of fatigue and it's hard to tease out what is happening here. So if I see that the score is high and is mostly driven by the physical component, well, usually what we do is we after a careful examination, we start saying, well, we need to perhaps do more physical therapy, more exercise, try to hit that target of exercise. And I know we're going to talk a lot about exercise, hopefully today, that we know that will be beneficial. But on the contrary, if we find that it's mostly that mental component or the cognitive component of fatigue, that's when we start looking at things like sleep problems or perhaps a medication side effect that we were talking earlier, right? So some of the pain medications that Christina mentioned earlier, the typical anti-epileptics like gabapentin, and sometimes they're great for pain, but they can also cause fatigue. So I think this very simple test can guide us into kind of dissecting the causes and then addressing the problem in a more informed way.
Very good. Thank you. There was a question in the chat box regarding that, so I just wanted to make sure I had the right name for it. Thank you. So on a similar topic, and I do want to touch upon exercise here as well, and kind of lifestyle management, but I wanted to stick a little bit more to the medical side of things first. So how does fatigue relate to disease progression or relapse activity, and should new or worsening fatigue prompt further workup?
So
Go
you
ahead.
want to start?
No, please.
I'll just start very easily. Generally, And again, as Dr. Miravalle had already mentioned, those primary drivers of fatigue are affected if if a patient with MS has a relapse, has a lesion develop, then there's more scarring, damage in the brain to those neurons and the connections and that electrical, if we're thinking electrically, they take longer to get to where they're going. So technically, yes, a relapse or disease progression could affect fatigue, which is again why we stress the importance of our good new disease modifying therapies. And what were you going to say?
Yeah, no, similarly to the point that one of the fascinating things about the brain is, and the more we learn about the brain, the more I feel that there is so much to discover, right? But one of the most fascinating discoveries that happen in when you look at the function of the brain is this concept of plasticity, which means the brain as an organ is highly adaptable. And so even though we have parts of the brain or neighborhoods that are kind of linked with certain functions. And when you affect those pathways, let's say with a lesion in multiple sclerosis, you could directly affect that function, let's say moving your left leg, and all of a sudden you have a foot drop on the left. Well, there are many areas of the brain that may be next to it, or perhaps on the other side of the brain, that could eventually learn to fulfill that role. So that concept of adaptability in the brain is something we call neuroplasticity. And this is something that is actually, the more we learn about that, the more we can actually help patients not only recover function through alleviation of that damage done early on through inflammation, but also perhaps more interestingly is by a redistribution of function in areas of the brain, sometimes remote areas of the brain. And we were able to see that for the first time with one type of MRI called functional MRI, which rather than looking at the structure of the brain, functional MRI allow us to see the function of the brain. And so patients inside the MRI can perform certain functions, usually simple motor tasks, and then you see which parts of the brain get activated by performing those tasks. And that tool is allowing us to kind of understand fatigue, because not surprisingly, for example, patients with multiple sclerosis, to perform a simple task, they're using more brain. And the reason why they're using more brain or more cortical activation is because it's a way to compensate for that dysfunctional or perhaps inefficient pathway that is a result of demyelination. So that was the first time we could actually see fatigue on an MRI.
I'm just going to throw a question at you.
Yes.
Would you agree that it depends on where the lesion load really is? Yeah.
That's a great question. So they've been, as you can imagine, multiple attempts to correlate lesions with fatigue. And for the most part, those attempts have been not successful. And the reason being, it's a completely different mechanism for fatigue. So in a sense, lesion load, as much it does not correlate with fatigue, as much as, for example, other outcomes like brain atrophy. So the size of the brain, which makes sense. And also certain parts of the brain. So there is a pathway that goes between what we call the basal ganglia in the brain, which is this deep nuclei in the middle of the brain, and connections between those ganglia and the frontal lobe. So those pathways have been linked directly with fatigue. And so we were earlier talking about the primary type of fatigue, and that's kind of like where we can probably localize the area. But then going back to the secondary type, so the deconditioning or the fatigue that comes from overexertion of the brain in order to compensate for inefficiencies, that type of fatigue is the one that is also very susceptible for improvement when we exercise or when we do physical therapy. And I'm going to leave it hanging there because I know there are going to be some questions about not only how can exercise help, but why, which I think is fascinating.
Well, perhaps that is a good time to jump to exercise and just overall lifestyle modifications and what can we potentially be doing to help with fatigue. And we can always jump back, right, to some of these other items. But Let's talk about that. So often patients will say, well, I'm so fatigued. How can I engage in exercise and can it ultimately help? Because so let's jump into that and maybe you can help explain that a little bit.
Sure. So we know research has shown over and over again that even different types of exercise, even once a week routinely, can significantly improve patients' fatigue and their perceived fatigue. It's very much a vicious cycle where I'm so fatigued, I don't have the energy to work out, I don't have the energy to even go on a walk. And then, our muscles get weaker and it just kind of follows a vicious cycle. But really, the evidence shows that even one day a week of low to moderate exercise can significantly improve that fatigue for our patients.
Absolutely, and that's something that we are changing now. The recommendations in the last decade. Probably those patients who perhaps were diagnosed in the 80s and 90s, their doctors will tell them, don't move, don't exercise,
Right.
because they will think that overheating can make the symptoms worse, right? And we want a 180-degree change now. We are saying actually the exact opposite. And the reason being, as Christina mentioned, that every study that we look at, that they looked at different types of intervention of exercise, consistently shows a benefit. And probably to start with the most practical point, we now have guidelines on exercise. They're called the Canadian guidelines for MS patients, and not because it only works in Canadians, but actually it was the study was supported by the Canadian National MS Society, so the name has to include the Canadian, but actually that was developed mostly by Americans. And so those guidelines are published now in 2018. I'm part of the committee that is reviewing the guidelines to publish the new version of that. But basically, now we have a dose of exercise for everyone, but also we can actually narrow down to particular patients based on their ability or disability status. In general, we recommend 2.5 hours a week and for at least 6 months. That's kind of like the minimal, the threshold in which we know that exercise will start to work. And depending on where you are in your age group, let's say you're in your 50s, well, 50% of that should be cardio and 50% of that should be strength training, okay, or some sort of resistance training. Doesn't have to be like heavy weights, but something that actually will activate the muscles. So if you get more towards your 70s, then you bring more of the resistance training and less of the cardio, right? So you do 70% resistance training, 30% cardio. And if you're younger, perhaps you need more cardio, particularly if you're overweight, right? So we kind of narrow down the recommendations to a particular patient, but in general, that's what we are recommending these days.
And of course, that'll vary based on prior exercise experience, if you're comfortable doing it, if you need guidance, which I recommend for a lot of my patients, just going to physical therapy strictly to help them come up with some sort of exercise routine if you're not comfortable with it on your own.
I think that's a really great point that you just made, Christina. It is oftentimes so difficult to just start the process and not know how to start and what feels safe and comfortable. So getting some good points from a physical therapist, I think, I mean, they can work their magic. I always think physical therapists are amazing, can really make a big difference. There was a question in the chat box regarding thoughts on vibration plates for exercise.
Yeah, they're
Any
great.
any information on that?
Yeah, I'm a big fan of that. So I call them the power plate or vibration plates. Those are great for when you want to do isometric contraction of the muscles, meaning let's say you have minimal mobility or ability to move the legs. You're in a wheelchair perhaps, and you can't move the legs too much. You can still apply this very gentle vibration. Those are plates that actually will vibrate, and that passive movement is good enough to actually activate muscles. Vibration plate also helps to some degree with spasticity. So yeah, I'm a big fan of that. It really depends where you are and what level of ability you have, but could be a great strategy.
And suggestions of types of exercises, particularly if somebody is having disability or weakness, perhaps in their legs. Obviously, this particular individual mentions that they ride a Peloton bike, but do you have any other suggestions?
Yeah. So as Christina mentioned, if you have some degree of disability, even if it is a simple, subtle foot drop, the first step is to work with a physical therapist, because sometimes when you have an asymmetric gait, if you just do an exercise and without supervision, you might risk to overuse certain parts of your body, and that could lead to pains or more spasticity. So, as a rule of thumb, if you have some degree of disability, start with a physical therapist. So, second is usually what they target is to try to strengthen the muscles that are weak, but also, most importantly, the contralateral side. So the other side, to strengthen those muscles there, because those are the ones taking most of the burden of the movement. Usually when we have weakness in the legs, we think that the only muscle group that we have to strengthen is the legs. And actually the most important muscle group to strengthen is actually your abs and the lower back, because that your glutes. That's the area that is actually going to take a lot of burden. So one of my favorite activities for that type of situation is rowing. Because in a rowing machine, actually, first of all, you have minimal chance of falling. You're strapped into a machine. And if you think about it, you are exercising pretty much your entire core, from your feet all the way to the shoulders. And you are doing both cardio and strength training. So it's a really efficient way to exercise, particularly if you have some degree of asymmetry on the legs.
And typically, along with that, you can, depending on the machine that you have, you can adjust the resistance. So as you build up your strength, you can continue building.
And a couple of questions here that have come in, and I know there's so many new devices that are out there on the market that can help with such things like foot drop. But any thoughts around using TENS or EMS devices, or what about electrical pulses being used to help with foot drop? If you can maybe just comment on that.
Yep. Also, big fan of electrical stimulation. TENS units are great. A good physical therapist will recommend TENS units if they find that they might be beneficial. The typical indications are when you want to passively stimulate a muscle group that is perhaps denervated, that is not getting enough information from the brain, and kind of like to strengthen that or to activate that. And the second one is spasticity. And sometimes when the muscle groups are too tight, you use TENS units to kind of like help to relax. So probably we should explain this. I think it's helpful. The muscles themselves, without any type of intervention from the brain, they can have activities. So if you let a muscle cell actually activate and deactivate, it's going to work. So the function of the brain, in a sense, and the nerves is to kind of control that activity, control that movement. So when you interrupt that communication, what is going to happen is all of a sudden the muscle has no supervision anymore. It's like having teenagers in your house for an entire weekend without the parents, right? They're going to make probably they're going to party all weekend. So the muscles do the same thing, right? So if they don't have that communication from the brain, they're going to do whatever they want. And then they get tired and they get spastic, right? So spasticity, in a sense, is a result of that chronic denervation, that all of a sudden the brain is no longer controlling the muscle to make sure that it's healthy. So when you do with neuromodulation, is you mimic the signals from the brain. So you're putting something next to the muscle, you're creating an electrode that is going to send signals that, in a sense, mimics that signal that should be coming from the brain. So it's like, going back to the example of the teenagers, it's like sending a friend to your house to make sure that they're doing okay, right? So you kind of try to mimic that function. So neuromodulation is great, helps not only to restore function, but also to preserve the integrity of the muscle and to some degree address spasticity.
There is a question in the chat box that came through that I absolutely love. And I have a feeling both of you will really like this one too. Does exercise help with neuroplasticity and the brain developing workarounds for movement, strength, balance where lesions may be? Love the question.
Absolutely. Absolutely is the answer. Yes, it does. It can. It may take a while, but there's definitely workarounds that you can do. Just like I'll tell my patients if they have cognitive concerns, exercise your brain, do new things, whether it be a new language or puzzles or whatever. If you're constantly trying to fire that signal and it's continuous, the brain will find a new way.
Absolutely, and so for those of the if someone in the audience, we run also a master class. It's called a 3-week brain health master class, and we dive a little bit deeper. But just to tell you some of the reasons we recommend exercise, there was a study looking at functional MRIs in patients with MS, and as I explained earlier, most patients had fatigue. And when you do the functional analysis, the entire brain was lighting up to try to help perform that activity, right? So there was this overcompensation of the brain to try to kind of help with movement. So those patients were then enrolled into a 3-month program of rehabilitation and physical therapy. And at the end of the 3 months, they did the same functional MRI and they measured fatigue. And for those patients who improved fatigue, there was a substantial reduction in the amount of brain needed to perform that activity. So there was a reduction in the cortical activation, which means that in a sense, what you're doing is making the pathways more efficient, and you don't need to rely as much on brain cortical activation. And of course, fatigue is going to decrease. And that happens actually to anyone at any point. That can happen when you're 5 or when you're 75. So I think that concept of plasticity truly doesn't matter where you are in your MS, how much movement you have at baseline. Even if you have minimal movement in one arm, you can still benefit from that process if you activate that arm.
I think that I'm so glad that question was asked. Really, really solid. Question about thoughts on red light therapy.
I use it, but I don't know if there is any thoughts in MS. But I know that it's healthy for aging, for skin. I haven't seen anything that is directly related to multiple sclerosis.
No.
If there is some degree of overheating, I will be cautious on. I mean, you cannot hurt yourself, but perhaps might increase fatigue. But I haven't read anything. Have you seen anything, Christina?
No, nothing even large, nothing that would suggest it's harmful either, but the heat would be my only concern, really.
Yeah, and we will most definitely get into, since we're in the summer months and heat is a big issue. I do want to talk about that, but to just move back a step, when we were talking about plasticity, we focused on primarily lesions in the brain. What about when there are lesions in the spinal cord? How is there any way to find workarounds in those situations?
Yeah, that's tricky. The spinal cord is this very tight group of pathways that actually converge into a very narrow canal. And so there is no much in terms of reserve around the spinal cord. We have a lot of brain reserve. So we can utilize a brain reserve to compensate, to generate plasticity. In the core, we don't have a lot of space. So if a lesion is present in the core and that lesion is causing those pathways, then becomes very challenging. Talking about technologies, one of the most exciting parts of the next wave of technology applied to MS is the field of exoskeletons. And through what it is ultimately multiple areas of neuromodulation through an external device. And so with exoskeletons, what you can do is provide support, but also stimulate the muscles that bypasses the brain. So it is very new, very recent, but so far the results are very promising, including patients who perhaps are in wheelchairs, they can move, and they are able to ambulate through the assistance of these external devices. So I think a lot is happening in research. And hopefully we will see very soon some of those results.
Yeah.
Excellent. This has obviously sparked something with this audience because we have a lot of questions around the exercise aspect. Something that was written in that I'm not familiar with. What about a HOCAT machine or PEMF? Can those be preventative or only to treat a current symptom? Are you familiar with this, either
I
Dr.
never heard
Miravalle?
of that. No.
Me
Have you heard of
either.
that, Christina? No, never
I
heard
have
of it.
not, no.
Okay, yeah, that's a new one for me as
So
well.
if whoever asked the question, maybe they can tell us a little bit more or type some more information. I'll be happy to look at that. Actually, I will say in terms of exercise, sometimes simple is better. So one of my favorite exercise, particularly for patients with high degree of disability, is a book. And so I often explain that to patients. Just grab a very heavy book, ideally with, hard covers, and put that on your leg, and put your hand on top of that, and just lift the leg against the weight of the book, right? So that works really well for patients in wheelchair, for example. Do that 10 times, and then repeat the same thing on the other leg. Then grab the book and do biceps exercises on one hand and do biceps exercises on the other hand. And then when you're done, open the book and read a chapter. So you're stimulating your brain, you're stimulating your muscles, right? And what I like about that recommendation is that you don't need fancy equipment.
No.
Most of the time, simple things go a long way. And that's actually supported by research. So there was a large study looking at supervised exercise versus unsupervised exercise. And the supervised group, the cohort that was enrolled there, they had actually physical therapies and people like controlling what they were doing, and they were calling them 3 times a week, and they were really on top of that to make sure everything was done perfectly. Whereas the unsupervised group, they were given simple recommendations and say, hey, you go home and do it 5 times a week. Well, at the end of the day, everyone improved, and very similarly, right? So what we are learning is, at the end of the day, it doesn't matter necessarily. I mean, of course, we always want to target the therapy to your needs, but once you have those recommendations, it's truly up to you to do that, and with simple strategies.
Absolutely. And I'll add to that. We know, the prescriptive or our goal guideline for exercise, but for a lot of my patients who don't do anything, I will say 2 minutes. If you can get 2 minutes consistently, that's somewhere to start. Starting low is better than not starting at all.
Yeah, and I think that's so important too, to make that point. And we had a patient with NMOSD who was paralyzed practically, and she made a point to just do 1 minute of walking on the treadmill, and she's now been running marathons. So it's amazing how like baby, just tiny steps can have tremendous results. So just starting somewhere is always great. But I want to shift course a little bit, sticking with exercise though. And here we are in the summer months. It's been incredibly hot already in June. How, looking at heat or warm weather, can that potentially worsen MS, fatigue, and other symptoms? How should people go about even trying to exercise in the heat? If we can maybe talk about that.
So heat is a very well-known sort of trigger for a lot of MS patients. There's something called Uthoff or Uthoff's phenomenon. And this is where basically any heat or overheating of the body will trigger your prior symptoms. Maybe it's fatigue, maybe it's spasticity, cognitive issues, whatever it might be. And then once you cool down, those symptoms dissipate again. Very, very common and often a concern for exercising. But luckily nowadays we do have a lot of products. There's commercial cooling products. You could use just a fan or a bag of ice. My favorite for the summer, or actually year round, is just aquatic exercise if you have access to that, because The buoyancy of the water is helpful, along with just the temperature generally of the water, as long as it's not superheated. But there's lots of options, and pacing yourself. So if you know you overheat when you hit 20 minutes, maybe do 15, take a little rest, and then restart. Those types of things can help.
Yeah, absolutely. And drink plenty of water. Maybe before go for a run or walk, put that water bottle in the fridge, in the freezer, and take it when it's completely iced, and then you can use that to cool off, and then when it melts, you can drink it. Right, so it becomes these like simple techniques. Again, that you don't need to invest too much money on things, but stay hydrated, stay cool, plan your walks when it's cooler, and then as Christina mentioned, try to pace yourself.
I always like to point out to patients as well that MSAA has a great cooling program where you can apply to receive cooling devices. So something worth looking into for folks who are trying to exercise in the heat. But the cooling towels, cooling vests, they're all really great. Lovely. Well, what about symptomatic medications are commonly used to treat MS fatigue, and how effective are they truly?
I can take a stab there first. So, I use them, and I probably should start with the data, right? So there were now multiple studies looking at the efficacy of the psychostimulants, the typical Provigil or Novigil, Adderall, Ritalin, for MS fatigue, and the results are all over the place. But for the most part, they were inefficient, and so it's not because they don't work, but it's because they're not used correctly. And I believe that the correct use of these medications is, first of all, understand the type of fatigue. And this brings us back to the MFIS, right? So medications like Provigil and Novigil, they're usually very good for that physical fatigue, not so much for the mental, but more for the physical fatigue. Take it in the morning if you're going to take it, as soon as you wake up. Don't take it in the afternoon, because then you won't sleep. You're going to stay awake, and then the next day you're going to be more fatigued, right? So you have to take it very early in the morning. And the second advice is, if you take that, exercise. Because the last thing you want to do is take a psychostimulant that is going to give you extra energy, and then you don't do anything with that extra energy. So if you take the Provigil and then you sit in your computer for 5 hours, then you're going to have irritability, insomnia. You have this extra energy that you didn't use. So take that Provigil as extra credits and use those credits to exercise more. So if you do that, then they work.
Fantastic. I had missed a question that had come through when we were talking about Uthoff's phenomenon. Sorry, I'm kind of jumping back and forth here. I apologize, but I don't want to miss this question. If somebody continuously is working out, and despite Uthoff phenomena, can there be any issues that they should be sensitive to?
Yeah, so as Christina mentioned, Uthoff is not damaging your brain or your spinal cord. So what is happening is that these areas of lesions, they're going to change the myelin around the nerves. And myelin is fat, right? So, and myelin is where the electrical stimulation travels, right? So going back to the wire example, myelin is like your plastic around the copper wire. Different to the wires is that the information in the brain travels through the myelin, doesn't travel through the copper wires, right? So that's the one difference with the nerves. So whenever you have a chunk of myelin that is demyelinated, what is going to happen is that area is going to have less fat and more water, and hence is going to melt faster. And we know that when things melt faster, when you go from a solid to a liquid state, the electrical transmission is going to be faster. So whenever you increase your body temperature, you change the chemical conformation or the molecular structure of myelin to a more liquid state, and those areas of demyelination are going to melt, in a sense, faster, resulting in faster transmission in those areas. So what is happening is that then you recapitulate the symptoms from those areas. You're not damaging the system, you're not causing more demyelination, and the moment the body temperature cools down, your symptoms go away. So from that standpoint, is not unsafe. However, what could happen is something common sense will tell us. So if you're hiking in the middle of the mountain and you overheat, and that brings balance issues from symptoms you had from a relapse 3 years ago, and all of a sudden you're losing your balance in a rock in the middle of the mountains, well, you can fall, right? So that's where the unsafe situation can occur, right? So that's why we say, well, try to avoid overheating so you don't risk situations in which perhaps you might become weaker or less balanced, and that can lead to a fall. However, the overheating itself is not going to damage the brain or the spinal cord.
Right. Yeah, important. Um, and I think that just triggered a question that came through talking about myelin. Is it possible to rebuild myelin? And if so, how?
I love your audience, Kathy. I mean, these are
They're
great
they're very
questions.
active. I love it.
This is great. Yes, of course, it is possible to remyelinate, and we all of us here have the ability to remyelinate. The body is a beautiful organ, and we have the abilities to do so. However, it becomes very difficult after our 30s, right? So remyelination is very active early on. So we currently don't have therapies or medications that will help remyelinate. There are many in investigations, and there are different targets that might be perhaps very interesting to see. However, going back to exercise, right? So one of the areas that perhaps is most fascinating to see is something we call neurogenesis, which is the generation of new neurons in the brain. And we always thought that you're born with X number of neurons and you cannot make more neurons. Well, that's no longer true. We know that some parts of the brain, small areas, have the ability to generate new neurons. Not surprisingly, the area that we store memories, right? So that's how we can create more memory. So that the part of the brain called the hippocampus can generate more neurons. And there are few things that actually can make that neurogenesis more effective. One is exercise. And the other one, guess what? It's stress reduction and mindfulness. So those two things together have the strongest data in promoting neurogenesis in the hippocampus. And conversely, patients actually have improved memory and cognition. So I think going back to exercise, there are so many benefits that in a sense you can't go wrong.
And putting together what you just said, exercise, as we know, has been shown to decrease stress overall. So those together are a good
Absolutely.
thing.
Absolutely.
Well, I know we talked a lot about exercise, and it is such an important topic. But again, going to our topic for this evening, fatigue, let's maybe shift and talk about the role of nutrition and diet and how that might help with managing fatigue.
Yeah, absolutely. We know that diet is important. There's not one specific diet that I would recommend. There's been a lot of research on multiple specific diets, but again, nothing has really been above and beyond any other specific diet. I would tend to usually I tell my patients if you're looking for something specific, lean more towards like a Mediterranean fresh, as try to get a vegetable with every meal, that type of thing. But I wouldn't recommend a specific diet, just avoiding sugar as you can, maintaining your nutrients as best as you can as well. So things that I often look to when somebody first has a symptom of fatigue is checking those nutrients such as B12, even our vitamin D, even our regular electrolytes, magnesium, potassium, all of those. Those are things we really should be getting and maintaining through our diet. And oftentimes, specifically here in the US, that's very, very difficult to do.
I agree. Similarly, I follow more the Mediterranean diet path. The MIND diet is a Mediterranean diet plus a low sodium diet. There's some strong data there. And to Christina's point, a couple of things that are important to remember. One is sometimes eating smaller portions in more often intervals is better for fatigue. One of the mistakes people have is waiting to eat to get too hungry, and then all of a sudden your blood sugar levels drop, and then your blood sugar spike again because you ate a lot, and then you have these ups and downs. So try to maintain a steady state by eating smaller portions throughout the day. Related to that, I know that some news are promoting the intermittent fasting. Be careful with that, because even though there are some benefits for intermittent fasting in terms of weight reduction and weight loss, it's not good for fatigue, because all of a sudden what you're doing, you're exposing the brain to a prolonged period in which has a inadequate amount of glucose. And when that happens, of course, the brain is going to just try to compensate and doing other things. So try to not do that if you're having fatigue. And actually, contrary to that, try to eat at more regular intervals and shorter intervals. And if you choose to eat carbs, which you should, I mean, carbs is, remember the brain uses 20 to 25% of our calorie intake, and most of that is carbs. So we need to have proper amount of carbs. Try to go to the complex carbs, that the whole grain and the more complex carbs, as opposed to, like, if you do rice, don't do the white rice, just do the brown rice. I just learned there is a purple rice. I didn't even know, but it's delicious. So there are all these different color rices, and they're better than the white rice. So why is that? Because complex carbs take longer to be metabolized. And rather than going to the spike of sugar and then nothing, like you get with the simple carbs, with the complex ones, you have more of a steady state of metabolism. And that allows the brain to avoid these ups and downs, and allows more of a steady state of glucose delivery to the brain.
I love that you pointed out the purple rice. Just a little throw out for everyone in our audience. I know another nonprofit organization, wonderful nonprofit, Yoga Moves MS. They have an upcoming webinar about eating the rainbow, which is going to focus on nutrition as well. So something for folks to maybe look into. But we only have a little bit more time left here. I want to make sure we address some of these remaining questions that have come through. And we briefly talked about Provigil, earlier on as a medication to help with physical fatigue. Can you talk about any others that might be out there that might help also from a cognitive and psychosocial fatigue standpoint?
Yeah, so I usually use Ritalin or Adderall for more of that cognitive fatigue. They have more of a shorter duration of action, and they tend to help more with that cognitive fatigue, as opposed to Provigil and Novigil that are more of that physical component. Having said that, it's one of the things that you need to try and see how you respond to that. The other medication that often is used doesn't have an indication for fatigue, but helps with fatigue, is Ampira or dalfampridine or 4-aminopyridine. There are different names, and that's a medication that has been around for decades and helps with the speed of ambulation, but also patients anecdotally report improvement in fatigue levels. But then there are things that perhaps are non-prescription medications that might help. Some people feel that carnitine helps, and I was skeptical about carnitine early on, but then I started learning a little bit more about that, and there is no significant risks as long as you stay hydrated. And particularly the days that you're working out and if you're doing resistance training, taking extra protein or extra carnitine might help. And remember, when you exercise your muscles, most of that benefit is going to happen during the night after your workout. So before going to bed, hydrate yourself and eat extra protein, usually around 40 grams of protein after each of those workout days. So there are things that actually are non-prescription medications or interventions that actually are very beneficial.
Very good. And again, I want to be sensitive. I know we only have a few minutes left here. We did not even touch upon the mind-body approaches like mindfulness or cognitive behavioral therapy that potentially could help with fatigue. Maybe we could just touch on that real quick as well.
Sure. So there is evidence out there saying that mindfulness, cognitive behavioral therapy, different types of therapy and counseling can be beneficial for fatigue. I think that's going to greatly depend on the type of fatigue or what domain we're really looking at. However, when we talk about those secondary causes like depression and immobility, things like that, mindfulness and cognitive behavioral therapy can increase your mood, improve your motivation, which then, if those are the causes of the fatigue or at least contributing to the fatigue, it can significantly help.
Absolutely, it's huge. So look at the brain in MS. So there is this network in the brain that we all have called the default mode network. And that is a critical network in the middle of the brain that helps to, in a sense, activate the brain. It's a switch that goes on and off, right? So when the default mode network is activated, most of the cortical activity of the brain goes down. And that's usually when we kind of are in a state of relaxation, when we are doing mindfulness, when perhaps we are daydreaming, right? So when you're not thinking about something, but when you're just letting the brain, wander, and that's when this network is activated. And conversely, when we are paying attention to something, when you're writing an email, when you're reading something, the network goes down and then the cortical activation goes up. So this is a very well-known phenomenon in the brain. So what happens in MS is those two networks don't necessarily talk to each other. So sometimes what happens is that when the cortical brain wants to pay attention, the other network is also active. So patients are trying to read, but all of a sudden the brain is saying, well, we need to relax, right? So there is this constant state that leads to decreased attention. And patients often tell you, I'm trying to concentrate and there is so much I can do, and then I get tired. So one way that we can train those two networks to talk to each other is by doing meditation, because you're forcing all of a sudden to activate one pathway and to deactivate the other one. So when meditation is critical, if you can actually incorporate 10, 15 minutes a day, close the door, lights down, soft music, don't let anyone distract you, and just do it. I think you're going to see much more of the benefits, similarly to what we see with exercise.
Yeah.
Go ahead, Dr. Weber.
Oh, I
Sorry.
was just going to add, sorry, that oftentimes, even for my patients with fatigue or those who have any type of insomnia, I often recommend mindfulness before bed, which helps them sleep or get back to sleep if they wake up. So you could be, helping both things.
Yeah. I think that's a lovely way for us to kind of wrap things up. And I know there were still several questions in our chat box. A lot of them got triggered from our discussion around nutrition, even how critical are vitamins and which ones are better. And perhaps you could just real quickly, because there is one vitamin in particular that is critical for MS patients, maybe we can just touch on that real quick. Which one?
Yeah, so I always recommend vitamin D for all of my patients. Other than that, it would depend on if you're deficient or having whatever symptom you may or may not be having.
Yep.
I agree.
Perfect. Well, excellent. I apologize that we're not able to get to all of the remaining questions. I am so thrilled by how interactive this became. This audience was fantastic. Thank you for all the great questions that came through. I want to give a big thank you to you, Christina and Augusto, for making this a really great session this evening. Thank you so much.
Thank you for having
Thanks
us.
for having us. Yes.
I hope everybody has a great evening, and we'll see you back in September. Thanks so much, everyone.